Dr. Nick Santavicca. We've got a handful of grads up in New York, and recently on EMcast I discussed and interviewed Josh Moskovitz and Adam Brenner, both of whom are right in the in the thick of things. And Nick Santavicca is in New York also. Nick is one of our graduates from the EMIM Critical Care Program, and he is working in New York City. Nick, can you and then just
the whole screen, huh, Dr. Mattu?
Give us a little bit of what you're going through, and then maybe if there's any other folks. I think I saw Josh there. Other folks in New York who want to chime in after you.
Sure.
Please go ahead.
Sure. So it's been a very trying time for sure in the Bronx. I work in the heart of the Bronx, and particularly in the Bronx, we've been hit really hard with the number of cases and the severity of cases. There are many articles that have been written and studies that have been done that show more severe cases and higher mortalities in lower income populations and underserved areas. And I can say from firsthand experience that it seems to feel that way. Probably in about February, we started hearing the rumblings of SARS-CoV and the potential of it coming over to the United States. And we started to gear up by doing it's called exotic infection alerts, so EI alerts. So not Tiger King, but actually exotic infection alerts, where we'd have to doff up, go into a room outside of the emergency department and evaluate patients. And maybe 2 or 3 a day, and then gradually increasing. And then probably in March, we started, even at that time, actually, we would start to see a lot of viral infections, high-grade fevers, which we would think slam dunk flu. We would check them for the flu in certain populations, and it would be negative. And it's unclear, we weren't testing for COVID at that time, but we did see a lot of people coming in with flu-like illness that never tested positive for flu. We just thought maybe some other flu that was, some other virus that was going around, and went on their merry way. They weren't particularly hypoxic, they weren't particularly unstable, so we discharged a lot of these people. Looking back now, of course, in the crystal ball, hindsight is 2020, potentially some of those patients had mild cases of COVID, tough to say. But moving into February, we started gearing up a little bit for it, preparing for it, and then March hit, and we started seeing an explosion of cases come in. And when it came in, it tested the extremes of our emergency department. People were either coming in respiratory distress, severely hypoxic, tachypnic to the 30s, people that you would instantly say they need to be intubated, and they were undergoing they were in hypoxic respiratory. On the other end, there were tons of people, and I mean tons, I mean probably about 200 to 250 people that we were seeing a day that were coming in with just mild viral illnesses. And at our hospital, we have over 100,000 cases a year. We see on average between 300 and 400 cases in a normal day, both from an ambulatory zone or urgent care type of patients to critically ill patients. And that kind of spiked up to 400s to 500s, and then testing the extremes of ambulatory patients with mild viral illnesses or hypoxic respiratory failures. It definitely tested us and ran our resources rather thin. So as a result of that, we kind of completely turned the triage process and the process of how we viewed and worked up patients, and we had to split the emergency department and completely change that. So we actually increased our capacity on the critical care side of our emergency department and actually established tents outside of the emergency department to try and cohort these patients and evaluate them where they were getting swabbed and tested outside of the emergency department. Initially, it was extremely tough. It was probably, I'm not in the armed forces, I haven't been through any wars, but it's probably the closest thing that I've seen that I can relate to what people described as like war, healthcare in like war zones. There were people coming in very, very frequently in extremis, and we weren't able to really contain or have the resources dedicated to every patient. We would try to do the best that we can, but it was very, very difficult. People would be boarding in the emergency department for 36, 40 hours as our ICU started to fill up. And it actually caused our hospital to start to convert lecture halls, operating rooms, PACUs into ICUs, and try and call on other staff to manage that. So surgeons, anesthesiologists were starting to get called to man and staff these makeshift ICUs that we started creating in the hospital. So that lasted probably about 6 weeks. That phase, that surge that we initially got, and I actually tested positive for, and this kind of relates to how one of the big lessons that I think we should take away from this is always be prepared for the worst. That's like our mantra in emergency medicine: prepare for the worst, hope for the best. And we weren't prepared for the worst, and at least initially in the initial stages. Our PPEs were really, really scarce. We had to ration our PPEs. We were starting to take our gowns and reuse them, like hang them on an IV pole. We never had to reuse ventilators or turn ventilators or use ventilators for 2 people or multiple patients, but we were getting close to that where we started to really consider it, and things like that started to circulate among the residency and the staff on how to makeshift a ventilator for 2 patients. I do have to say though that the response that we got from other departments to lend a hand and help us out was pretty robust, and actually gave us a little bit of a shot in the arm in terms of motivation and camaraderie within the hospital. We had plastic surgeon attendings come down and swabbing patients in the ambulatory tents. We've had surgeons, OMFS doctors, neurologists, infectious disease doctors and residents pitching in an effort to help us try and contain that initial surge. Probably over and at our peak in the hospital, so at our particular campus, at our peak, we had 600 COVID patients admitted. And at most, we had about 150 of them on ventilators, and another 20 to 30 of them were on high flow nasal cannulas. And at this point, we've discharged over 3,000 patients since it first started. We currently have less than 300 admitted patients, and we are under 100 patients of 100 ventilators in use right now. So we're in our de-surge plan at the moment. We're closing down those makeshift ICUs because they're not needed anymore, and we're starting to see the people trickling in for pains that have been going on for months now. So people are being a little bit more daring and coming out for their complaints, which was really a change because after probably in the last week or 2 in April, or the second half of April, as we started to see the deceleration in our numbers, it has been a barren wasteland, our emergency department. The majority of patients at that time, I would say about 75% of the cases, or 70% of the cases that came in were COVID related. And we weren't seeing anything else for the most part. Strokes, no one had a stroke in the month of April. No one had a heart attack in the month of April. We're starting to see a couple of them, and we're starting to see more come in now. And the volume's starting to go up a little bit, but for the most part in April, it was very different than what we were used to.
I know Josh is online. Josh, do you want to add any thoughts from your standpoint? And then maybe after you finish, we can just have people.
Yeah, sure. You know, pretty much what Nick said was 100% accurate. The only thing that was nice for us is that towards the latter half, we did get some extra resources that kind of came in outside the facility. So we were able to get some FEMA nurses, some FEMA physicians, some PAs. And so in our tent, as an example, we utilized a lot of non-emergency capacity out there, mostly an attending physician overseeing the facility. But we had dentists in the tent, we had pediatric residents doing adult patients in the tent. I got these 2 PAs from urgent cares who came from California and Florida, who were phenomenal. We trained them up on how to operate, and everyone was overseen by an ED attending. But really, that's where the saving grace for us was to support it. And like Nick says now, our volume is really, really low, and we still have all these agency staff here, so we're very flush. As a city system, we're not used to such high numbers of providers, so it's kind of an interesting mix right now out there.
All right. I should have introduced Josh before putting him on. Josh graduated from the EM program in 2010 and is working at the Jacobi Montefiore Medical Center. So questions for everybody? Any thoughts?
If you have any questions, feel free to unmute and ask.
So one question from Alita. At what point did you guys realize that this is far from normal operations?
So okay, I'm off mute. So initially, I did a 180 on this topic. So initially I would, when I heard all the reports in China and was doing the initial reading, I actually thought this was on the spectrum of influenza in terms of the severity. And then when I saw it, probably, I would say in the middle of March, beginning to middle of March is when I started to see that this was possibly taking a turn for the worse, and the amount of patients that came in with infiltrates and this viral pneumonia and pneumonitis, it literally felt like Groundhog Day. Everybody that came in, viral syndrome pneumonia, viral syndrome pneumonia. And it was really interesting. And well, I mean, I'm going to enter my niche of critical care here, that these patients, and this is the big controversy over COVID, is these patients have what looks like ARDS, they're hypoxic like ARDS, but their lung compliance and their lungs are just not acting like typical ARDS. And their work of breathing was so high. And that's the thing that really was difficult, because there was a separation. People were seeing something that they weren't used to. And you have people in academia who were calling this typical ARDS. It wasn't really acting like that. And you have another group, even Gananoni, who's a huge like intensivist pulmonary guy, ARDS, like Mount Rushmore in terms of academia, who's calling into question whether this is true ARDS. So you have this fight and this opposition, almost a line drawn, where you're going, treat this like typical ARDS via ARDSNet protocol, or do we kind of abandon that mindset for something that we've never seen before in uncharted territory? So there's a little bit of a struggle here, especially with me, where I try to practice evidence-based medicine as much as I can, where you're kind of torn and you don't know exactly which way to go. As this has gone on, there's been some protocols thrown together, again, not driven by a ton of evidence in terms of anticoagulation, in terms of treatment protocols. So it's tough. It's tough because you're trying to dip your toe in uncharted waters. You don't know exactly, whether you're doing harm or whether you're actually benefiting the patient.
Well, I'll add to that is, for us, I think one of the big fails we had here is we treated this like Ebola in the beginning. I've heard some people talk about this. The first case I remember we had back in late February, actually, this case came in from China, and she's got a flu-like illness, and called the Department of Health for guidance, and there was very little guidance in the beginning. It was very, very obscure. And these cases were testing positive for flu in the beginning, so we were still kind of confused by it. But we're going to each room as if it was, an Ebola drill, where 3 people are watching us don our gear, watching us doff our gear, we're throwing everything out. And I think when the surge hit, you realize, holy geez, I can't take my gear off, because there won't be enough gear. And similar to the toilet paper problem around the country, is everyone just started grabbing everything they saw on the shelf and running away with it. So while we had 8 boxes of N95s in our back room for a year, it was gone the next day. Like we didn't even notice. It was just, we turned around and it was gone. And so we had to open a command center to legislate the PPE. I saw one of the questions was about PPE. And so we had to kind of really, we rolled a card out in front of our resus space, so if trauma came in, that's when you were allowed to put them on more liberally. But also trauma's really dropped off substantially for us. We have a level 1 trauma center out here. We really have had minimal trauma activity until really about this last week. Now the stabbings are starting to occur again in our neighborhood. With the PPE itself, everyone started inventing their own PPE. I remember staying in the ambulance bay watching some guy get dressed in a bubble suit, a full Chemex suit coming in. And A, had no clue how to even put it on, or was not even wearing it properly. B, I don't even know who this guy was. Probably was some physician from upstairs, but just kind of walking to the ED. We have nurses who are putting on all this stuff and then walking to the break room with it and sitting on the couch. And so there's a lot of confusion about how to properly wear it, definitively how to take it off. And I could say, I saw a question about being sick. A lot of our staff members did get sick, at least a quarter. went out on leave at some point. And I think, my opinion is, a lot of it was related to the improper utilization of PPE, not so much the lack of availability. People taking their mask off to drink at the desk, touching their faces while working. It was extremely difficult to manage that, that situation, and people got very passionate about it and very particular about it. And so trying to guide them on it was very, very difficult because they were very certain what they were doing was correct.
So with that, Nick, can you talk about you testing positive and your course?
Sure. So I as Josh kind of said, some of the doctors and the staff went out and actually bought their own PPE and N95s and these huge respirators. And I did that. So I actually bought a couple. So the first one I bought looked like a really cool, like ski mask, Bane kind of thing from Batman. I put it on, and kind of what Josh said, I think, especially with that on in the emergency department, I remained covered. Eyeglasses, eye protection, and an N95 that I provided for myself almost all the time. Every patient, whether they came in with a toe fracture or toe swelling or viral syndrome, I pretty much gowned up for everybody. I tested positive. I was totally fine working shifts, doing my normal daily routine. April 1st, I woke up. I had a bad headache, splitting headache. Took my temperature because I kind of know if I have a fever, what it kind of feels like. Took my temperature and it was like 99.7. And I said, oh geez, is this the beginning of it? And I'm living with my fiance, and she's a little bit of a type A personality, very high anxiety woman. So she like stayed in the other room, and I was trending
Nick, be careful.
I know. I was
Careful
trending
what you say, Santa.
She's high anxiety. She'll tell you. So she was staying in the other room. I was trending my temperature, and I just had the thought that, I think I'm going to be febrile. I think I'm going to spike a temperature. Sure enough, I went up to 100.7. I got tested rather quickly, and it came back positive. And for the first 6 days, I was actually for the first 4 days, I was spiking temps to 102. Nothing really other than that, other than when my temp would spike, headache. And I'll tell you, just a piece of advice, here's a pro for everybody. If you get a headache, take a nice warm shower. It is amazing. So I did that every time my temperature would spike, and threw Tylenol at it and everything like that. And I was relatively fine once my temperature went down. On day 6, my temperature went away. I was low. When people say low grade, I mean like 99s, 99.5. So not technically a fever, but low grade temps, higher than my normal. And every time I would take a deep breath, I would feel something. It would be a little bit of a pull. Not a chest tightness. If I was talking normally, it was fine. Only if I took a big, deep breath in. And I noticed like going down to get the mail, 2 flights of stairs was a little bit harder than it was. Kind of like hiking in Colorado at 9,000 feet. That's kind of like the feeling that I felt. So I took my pulse ox. It wasn't reading 100. It was like 94, 93. And I was like, okay, so this is phase 2. And I went in to just kind of see how bad it was, to kind of gauge how I was going. And I got an x-ray. I had infiltrates. I didn't have diffuse infiltrates. It was very mild in terms of the infiltrates that I was seeing. And at the time, we were doing hydroxychloroquine. So I took hydroxychloroquine. My QT did not prolong. I did not get arrhythmias. I survived. And for the next 12 days total, I would still have this low-grade temperature and a little bit of shortness of breath with exertion of about 2 flights of stairs. It would go away rapidly. My heart rate would go up to about 130 after moving or up those like 2 flights of stairs or minimal exertion, and then resolve in about 3 to 5 minutes. And then after that, I've been fever-free. Symptoms are getting better. Able to walk around now with a little bit more energy.
Nick, is Josh? Oh.
Go ahead. Somebody ask a question.
Yeah. So, obviously New York was kind of one of the harder hit areas in the country. Have there been any talks so far about kind of what the plans will be, or if anything's going to be done differently if there's a sort of second wave, or they like a repeat in the winter or fall coming up?
So I've been trying to kind of test the waters in that regard of our leadership on what are our plans for in the winter, when now we have to worry not only about flu, which up until the coronavirus came around, we were having a pretty bad flu season. At least the early part of it was indicating we were having a lot of higher numbers and a higher slope in prior years. And then once Corona came around, it kind of it took a nosedive, and we didn't see any flu for the most part for the second half of the flu season. But now we're gonna have to wrestle with flu and Corona and separating those two out. I think we're gonna be we're gonna utilize that tent outside of the emergency department a lot more, and I'm trying to raise awareness about actual proper airborne precautions and isolation precautions and PPE in case that happens. Right now, with our lack of space and lack of resources, we're having a tough time carving out areas and cohorting a lot of these sicker, more critical COVID patients that might need to utilize high flow nasal cannula or other non-invasive procedures. Not necessarily. I mean, we've kind of really thrown out non-invasive in this pandemic, which is sad because that was one of our rescue maneuvers for a lot of hypoxic respiratory failures. So we're doing now high flow as kind of a rescue procedure, or non-rebreather, and then if they don't improve after an hour or two or show deterioration, we wind up intubating.
So we're actually a little different here at Jacobi, in the sense that we kind of try to decrease innovations actually.
Oh no, yeah, we have done that.
Flow and the BiPAP. We've actually took a lot of our ventilators and converted them to high flow operating machines to try to minimize that. We were having really, really horrendous mortality rates here with the intubations at upward of 80%. Or actually pulling the data now to publish it, 80% mortality rates here on intubations. And so we converted non-clinical space into clinical space, like the PACU became an ICU, and they're doing predominantly only high flow or BiPAP devices there. I think we've got about 15 more high flow devices into the ED, into the hospital, and trying to exclusively do that. I mean, the question for me that I don't understand it, I wish maybe we can get answered is what is the risk of aerosolization here? What is the actual risk versus theoretical risk? I think a lot of it still is theory-based, and we don't know the facts on that, so we're all planning for the worst, planning for the aerosolization, but I don't know if we really know. Operationally, I did see a few questions pop in. Hard part in the beginning for us was the lack of assistance from some departments in the facility that I'm sure a lot of you guys experienced as well, such as OHS. A lot of people are coming to the ED to get tested who are employees. Oh, I was sick, OHS is closed, I'm coming to the ED to get tested, what do I do? And that really messes up your operations when you're in the middle of, 6 stretchers deep in the hallway trying to deal with a sick employee now. And then with the false negative rates on top of it, what am I telling them to go home and do? And there was a lot of not good guidance coming from our departments of health in the beginning, explaining who should stay home, who should come back to work. And it was really a tenuous time in the beginning, unfortunately.
Guys, one other question had come up from Mimi, and this is a question that I wanted to ask also. A handful of us as faculty knew Lorna Breen, and as everyone knows, she was an emergency physician who recently committed suicide. And that kind of relates to the question that we want to ask. How are people coping with all of this? I mean, you guys, all of us are trained to save lives in an area where there's pretty much nothing you can do in many of these scenarios. You intubate a patient and you figure, well, once you intubate a patient successfully, they're going to do better. But 80% of these patients end up dying from what you're saying. What are you guys doing to cope with all of this? What are your colleagues doing to cope with all of this? And Mimi had asked about PTSD aspects of this. Any thoughts about that?
Yeah, so go ahead, Josh.
I was going to say, the one interesting thing for me that I noticed, more of an observation piece, is that at least our residents and nurses were a little more resilient in the sense that we had a ramp up. So we started off, okay, the cases are coming in and got worse. I definitely saw a higher rate of concern amongst a lot of travelers that came in, the female nurses came in, because they just got dropped in, and all of a sudden, wait a minute, I've never seen anything like this in my life, and it was very hard on them. We were doing a lot of palliative decisions in ED, which I think were the right decisions. You know, a lot of end-stage XYZ disease coming in from a nursing facility, in cardiac arrest. We were not really trying to expose our staff members to that. So trying to be more aggressive in doing the right medical decisions. And, you know, with the governor's executive order in New York, it kind of gave us a little more flexibility to really do what we should have been doing well before the pandemic, is making the right medical decisions for people. And so that was kind of a nice thing. The hospital's investing in some resources now. I do want to give one quick shout out before Nick goes to our residents. Nick and I share the same residency, which is at different facilities. He's at the Monty site, I'm at the Jacoby site. And so one of our residents did get very ill, and actually there was a really amazing piece in the New York Times about him. His name is Andres. If you guys want to Google that, they did a really great video interview, as well as a really good piece by a Pulitzer Prize winning writer. So I encourage you guys to Google Andres in the New York Times and take a peek when you get a chance.
Nick, any thoughts about the coping with all of this?
Yeah, this has been particularly tough, especially in the emergency department, where we're seeing all these, the number of patients coming in extremis, and it just being, like I said before, repetitive, and people suffering from the same thing, every patient. Like I said, it seems like 60% of the people that come in are COVID related. So it's hit our residents pretty hard. Our program has set up a lot of wellness programs. So either speakers, psychologists, inspirational speakers, activities, so yoga. We've also taken advantage of a couple of promotions that were done by companies that specialize in wellness and coping and stress relief, things like that. And we've just been very positive as a group. As our, all of our staff members have been very motivated, have been positive, just expressing positive words. And the camaraderie has really gotten us through. We've had an enormous output of people showing their support, the community writing on the streets, writing on the building in chalk, saying how much they support us. NYPD and FDNY have come around to the different hospitals, Jacoby and at Monty, on different days, pretty much closing down the street and lights and sirens on, showing us support. So little things like that have given us definitely a shot in the arm in terms of our mental well-being. But when you come home, not only is it trying when you're at work, but when you come home, it takes it takes its toll on your life outside of work as well. Like I said before, my fiance is living with her parents, so I get the apartment to myself. Good or bad? No, it's more bad. I miss her a lot. I miss her dearly. But it's tough. We video chat on every day, but it's tough to really have that that personal connection through video chatting. It only gets you so far. I haven't seen my family or my parents in person in a while, so that's the hardest part for me, is that social connection and that link with everybody else. But thank goodness that we have this, video chat and the technology to kind of bridge that gap and make it a little bit easier.
A couple of questions have come up, and maybe we can ask Stephen Liang to get thrown back into this, but questions about the test sensitivity. What kind of test sensitivity are you guys finding? And I don't know if Steve is still on.
So as far as test sensitivity, you hear a lot of numbers thrown out there, roughly in the 60 to 75% kind of range. There's still a lot of doubt whether or not it's a true sensitivity or specificity, because there's no gold standard that's being compared to. So we're not culturing viruses in every patient and comparing the RT-PCR versus that gold standard. But roughly about 70% is probably what we're looking at. I think there was a question about what do you do with a person who tests negative, but you still worry about COVID-19. And I would say, without a doubt, keep them on precautions and treat them as if they had COVID-19, and just see what the evolution of the process is. There's no perfect test for this disease, but the RT-PCRs in general are pretty good for most infectious disease diagnostics.
Dr. Whitting had a question about non-invasive ventilation. Let's see. Michael, you want to ask that question?
Sure. Does non-invasive really decrease the intubation rates? Like, how often do you see patients treated with high-flow nasal cannula recover without intubation?
That could be for anybody.
We had a lot of successes here with that, Mike. We, you know, I have a colleague that we brought here from another facility that was stranded in another ED in our system. They were overwhelmed. Queens was a much higher hit borough than the Bronx is volume-wise. We have the highest rate of death in the city, but Queens definitely have more volume than we do. And one of our two of our sister hospitals were really overflooded. We're talking about 150, 200 boarders at any given point in their ED. And so we absorbed quite a bit. And you know, a lot of these guys came in, we put them on high flow, and it made a huge difference. They may have been on BiPAP or high flow for 2 weeks, but they staved off intubation and eventually made it home to discharge. And so we're seeing it. I'd love to start pulling the data and seeing what the facts are on it, but definitely observing it is a real difference that we feel.
Yeah, high flow is really a great rescue device or modality for COVID. That and also the proning. We've been doing a lot of awake proning at our facility, reverse Schindellenberg and awake proning, and that seems to help a lot.
And Dr. Whitting, I can say that in the IMC where we have a lot of these patients, you know, we've been putting them on high flow on really high flow settings, and then just letting them ride. And even if they exceed the high flow capacity, you take them from high flow and you put them on a non-rebreather on top of that, just so they trap less ambient air as they breathe. We've had a lot of success doing that, because I think those are just on its face, right? I think those are patients you'd probably intubate if they weren't getting better, but we're just not, and we're letting them ride until they look like they're truly in distress.
Yeah, we've definitely lessened our threshold, increased our threshold to intubate. We're letting these people that are breathing in the 30s on high flow kind of sit there, and if they're holding their own, we're holding off on intubations. But it's tough, especially in the middle-aged population. Sometimes these guys really just don't do well on that. So we've definitely allowed people to quote unquote ride it out on high flow. And actually, in terms of some of the aerosolization, there was one study that did it. It was really elegant, where they looked at the aerosolization through like a thermal image, and it actually showed that high flow with a mask wasn't much more aerosolization, with a surgical mask, over it did not aerosolize. I think it was only like 13% of the particles aerosolized, which wasn't significantly more than a non-rebreather. So really interesting. I could send that link to someone if they want, but it was a really nice study.
So there's a lot of theoretical. Sorry, this has ended up being a thing that I've ended up reading a lot about. But there's a lot of aerosolization data about high flow nasal cannula. There's several kind of studies where they use like fog and lasers to look at how far things aerosolize. There's the vapotherm study where they looked at it, and then there's one other where they measured the particles at like 1 centimeter and 10 centimeter, and overall the risk of aerosolization on all those things on high flow is really low. But I want to emphasize, none of that is real world actual data where we're looking at the virus and where's the virus going and what kinds and who did when we do that, and what kind of rooms should we really put them in. So all the data that does exist is very reassuring about the aerosolization of high flow. You know, on, I want to say 60 liters per minute in someone with really healthy lungs at about 17 centimeters away from the patient, your risk of admixture, your risk of mixture with their aerosolization drops to about less than 10% in one of the models. But right, so that should, I think, give all of us a lot of reason to feel safe. But how this like fog model relates to what's happening with the virus is, you know, I don't know that anyone really knows.
Yeah. David, you're kind of stealing your own thunder from what you're going to talk about later on. So David will be back to talk about some more critical care stuff in a little bit. But Nick and Josh, I want to thank you all so much for joining us. And please stay on for as long as you can. Nick, I know you have you both have meetings coming up later on. But I also just want to say that on behalf of all of us, we really appreciate everything that you guys in New York have been doing. You've really been leading the way, and a lot of what we're doing is based on what we're learning from all of you guys in New York. So please send our best to your colleagues also. Stay strong. And again, thanks for joining us. At this point,